Okay, I think we'll start the meeting. I'm sure we'll be joined by more people. Just to remind people, this is a series of seminars on global health history on a variety of topics. We're fortunate that these seminars, they're organized by the Department of Knowledge Management and Sharing, and we are fortunate to have the support of the Wellcome Trust through the Wellcome Centre for the Study of History of Medicine at University College London, and now also joined by the University of York, who is also supporting us. Just to remind everyone that these seminars are also broadcast on the web, so if people, when they're speaking or later when asking questions, to make sure they use the microphones so that they can be heard by people who are also listening in via the internet, and also to give your names before you speak so people can know who you are. So my name is Human Moman, coordinator of Who Press, and then the format of the meeting will be that I will introduce the two speakers, and then we'll open it up for questions after both speakers have finished. So the first speaker today is Professor Muriel Gillick from Harvard Medical School, where she is the professor of population medicine. Professor Gillick is a geriatric physician and very interested in the topic of aging. She's recently published a book called The Denial of Aging, Perpetual Youth, Eternal Life, and Other Dangerous Fantasies. This is being published by Harvard University Press. I think she will then present more of her interests in her presentation. So I'll pass it over to Muriel to give the first.
Thank you. Can you all hear me? So first, thanks to the Wellcome Institute and the World Health Organization for giving me this opportunity to talk with you about my perspectives on aging. And I'd like to start by asking what image comes to your mind when I say the word aging. Do you see this, what I call robust aging? Or do you see this? I guess you don't see anything here. All right. Someone who's very frail? Or do you see this, someone who's ill or perhaps dying? So if you pick the first one, robust aging, then you're in tune with the prevailing views which emphasize what's variously called healthy aging, successful aging, or active aging. Healthy aging is the view embodied in popular books such as this one that stresses individual responsibility for aging and argues that with exercise, good diet, and the right attitude, most chronic diseases can be avoided and aging can be prevented, or as this suggests, perhaps even reversed entirely. Somewhat similarly, you have the model of successful aging that was espoused by Rowe and Kahn based on results of the MacArthur study, a longitudinal study of aging done in the United States, where they distinguished between what they called usual aging, where individuals became sick and disabled, and successful aging, where they don't, thanks to good lifestyle. So successful aging, as you see here, has three components: low probability of disease and disease-related disability, high cognitive and physical function, and active engagement with life. So implicitly, it defines those who aren't functioning at a high level, who do have disease and disability, or who do have cognitive impairment, as aging unsuccessfully. And then we have the World Health Organization Active Aging Framework, which starts by saying that active aging entails optimizing opportunities for health, participation, and security to enhance quality of life as people age, But this report, which you see here, also goes on to say that traditionally old age has been associated with illness and dependency, and any policies and programs that are stuck in this outdated paradigm do not reflect reality, and it's time for a new paradigm that views older people as active participants in an age-integrated society. So I think what's fascinating about this is that for the past 200 years in the United States and most of Europe, this kind of dualism, seeing aging as either good or bad, has prevailed. And while it's certainly important to acknowledge that there are many varieties of aging, and to recognize that aging doesn't invariably bring periods of disability, I think that the consequence of this dualism is that for both in the past and in the present, we tend to view everybody who's not robust as a failure. So what I'm going to argue today is that it's certainly important to promote prevention and foster robust aging, but we also need to accept that many people are not going to be robust as they age, that they will develop physical frailty or dementia, and something which seems to escape many of my colleagues in the United States, that we all do eventually die. So we need to find a way to allow all elders to retain their dignity. So what I'm going to do in my 25 minutes here is to try to describe something about how dualism has functioned historically, define what I mean by frailty, dementia, and dying, explain why it's really important to attend to all these conditions, and that the individuals who have them have needs that are different from those of individuals who are robust, and then try to give you a few illustrations of what it might be like to be in one of these states, and to elucidate both the physical and existential needs of people in each of these conditions. So a few words on the history of attitudes towards aging, at least in the United States. It was really fascinating to realize that before 1800 you had the predominance of a basically Calvinistic view that aging inevitably entails deterioration, mental and physical, that pain and disease are to be accepted as the punishment for sin. But at the same time, aging was viewed not merely as a period of loss and decline, but also as an opportunity for hope and redemption. Then in the early the middle to late 19th century, we saw the triumph of Victorian morality, the view that anyone who lived a life of hard work, faith, and self-discipline could preserve health and independence, and it was only the shiftless, the faithless, and the promiscuous who were doomed to a miserable old age. So as older people became perhaps superannuated in an industrial society that was dependent increasingly on heavy labor, old age came to be seen as a period of despondency and pathology. And then this shifted a bit in the first half of the 20th century to a view in which you had the triumph of scientific management. Social reformers began to see old people as sick and poor and unable to support themselves, but didn't see this as punishment for sin, and in fact felt that what they needed was they needed professional help. So social workers and geriatric physicians were those who were going to redeem individuals from this precarious state. So since 1980 or so, we again have a mythology of seeing old people as healthy, sexually active, engaged, productive, self-reliant. But this positive mythology, I would argue, shows no more respect for the vicissitudes of aging than the negative mythology. And as Thomas Cole put it in The Journey of Life, unable to infuse decay, dependence, death with moral or spiritual significance, American and European cultures dream of abolishing death entirely, and not just death, but frailty. So now I'm going to turn to what I mean by those people who are aging unsuccessfully and begin with frailty. Frailty is something that's very hard to define. It involves typically multiple chronic illnesses, no one of which alone would be tremendously problematic, but where the combination conspires to lead to impairments in the ability to care for oneself, as well as to enhanced vulnerability to acute illness. Frailty, I think, is important to realize is more than just disability, although disability or impairments limiting life activities are part of frailty. And it's more than just chronic disease, although incurable progressive illnesses are definitely a characteristic of frailty. It's perhaps best seen as arising from the intersection of chronic disease and disability in people with some sort of enhanced vulnerability, perhaps due to economic, social, or genetic factors. Why does frailty matter? Well, it matters because its prevalence is associated with age greater than 80 or 85. In the United States, probably about nearly half of people over 85 are characterized as frail. And if you look at the fraction of the population over 80 over time throughout the world, you see that it's already very high in developed countries with 195 million people today, projected to reach 326 million by 2050, and it's also rising quite fast in the developing world, going from 327 million today to 1.2 billion in the year 2050. We also need to realize that frailty is not likely to go away anytime soon. There's a lot of widely cited data indicating that the rate of disability, which is a major contribution to frailty, has been falling in the developed world. But what these data show is that that's not true for those with the greatest degree of impairment, those who are most likely to be frail. The non-disabled, that's the green, the light green, have, among individuals 65 and over, have gone down from 74% of the gone up from 74% of the population to 81%. But if you look at the top bar, the red bar, those with 3 or more impairments in their very basic activities of daily living have actually risen from 6.4 to 7%. Let's go on to the next group of people who might be seen as aging unsuccessfully, those with dementia. Dementia is a progressive cognitive impairment involving memory as well as language and the ability to problem solve. The most common form clearly is Alzheimer's disease, which lasts an average of 5 years from the time of diagnosis to death. So why is dementia important? Again, because of its enormous prevalence and its growing prevalence. These data are worldwide data looking at the numbers today and projections over the next 40 years. Dementia is not just a problem of the developed world. Just as with the previous slides showing the growth of the oldest old, those over 80, we'll see the rate of growth in those people with dementia actually greatest in the low and middle income countries, the sort of dark orange, where you see it rising very dramatically. It's actually, by comparison, we've reached pretty high numbers in the wealthier countries, and they're not going to, those numbers will not rise as dramatically. We'd like to believe that dementia is treatable, but actually if you look at the most successful group of drugs that we have, the cholinesterase inhibitors, this was the most positive statement I could find by any reputable medical organization on their efficacy, saying that they lead to modest benefit in a substantial minority of patients. And many people regard these benefits as of statistical but not clinical significance. We'd love to believe that dementia is preventable. The use it or lose it model is really enticing, and there are some tantalizing studies suggesting that if we only do more crossword puzzles, we'll be able to stave off dementia. But if you look at the State of the Science conference that was held just 2 months ago in Washington, This was their conclusion after reviewing extensively all the literature. There is currently no evidence considered to be of even moderate scientific quality supporting the association of any modifiable risk factor with a reduced risk of Alzheimer's disease. Not terribly encouraging. And then the last group of those one might construe as aging unsuccessfully, or those who are dying. And again, as I pointed out the obvious, the death rate in human societies is ultimately 100%. By dying here, I'm talking about individuals who have somewhere between 6 and 12 months to live, people who during that period develop progressively greater impairments in their daily activities and greater needs for basic care. So why is dying important? Dying elderly? Well, clearly the better we do in preventing premature death, the more likely we are faced with dying as part of old age. And this is just to show that there are many countries in the world, though clearly not all by any means, where the majority of deaths occur in people over age 65. The dying elderly are also important because their needs often differ from those of younger people. End-of-life trajectories are changing. In the era of infectious and traumatic deaths, people died precipitously, like the top slide that were fine and then boom, and we still see that top trajectory with some forms of cancer. But there's a different path for people with progressive organ failure, such as heart disease or lung disease, captured in the second line, and the trajectory for frailty and dementia is more like the third graphic. So my question is how we can ensure that we pursue the preventive strategies that are so important to try to keep people robust, but at the same time that we don't neglect the individuals who are frail, who are demented, or who are dying. And in the writings that I've done about this, I tend as a clinician to start with real stories and try to figure out, based on what happens to real people, what's important for everybody in each of these groups. So in the remaining 11 minutes, I will try to tell you a few stories. So let me start with somebody who's frail and tell you about Sam Dryden, not his real name, an 83-year-old widower who had diabetes, heart disease, and arthritis, and difficulty hearing. He lived alone in an apartment in senior housing, one day developed chest pain, summoned an ambulance, went to the hospital. This is the United States, so he was immediately whisked off to the catheterization lab to have an angiogram, found that he had multiple blockages of his coronary arteries, and bypass surgery was recommended. But Sam felt that open heart surgery would be much too much for him. He didn't think he'd come through it. He thought if he did come through it, it would leave him with a lot of impairment. His physicians were puzzled and said, well, if you don't want what we have to fix you, then maybe we should refer you to hospice. But what Sam wanted was something in between. He wanted to spend what time he had in his own apartment, where he had an extensive music collection. He wanted to be able to be near his family, spend time with his grandchildren. So what happened to Sam? Well, after his stay in a rehab facility where he worked with physical therapy to get back on his feet, he went home. He had weekly visits from a visiting nurse. He had an elaborate medication regimen to control his heart disease. He used an electric wheelchair to conserve energy. He got a special computer on which he could develop an interactive website so he could provide advice to businessmen starting out based on the sorts of work that he had done. He saw his grandchildren. He wore his hearing aids to listen to the music that he loved so much. And a year and a half after his discharge from the hospital, he was found dead in his reclining chair at home. So what mattered to Sam? Well, in the physical domain, he wanted to remain as independent as possible in his own apartment. He wanted to control his symptoms. Being unable to breathe, having pain in your chest is very uncomfortable. And in the psychosocial and existential domains, he wanted to help other people, and he wanted to listen to music, and he wanted to be with those that he loved. So what made it possible for Sam to maintain his dignity in the face of frailty? Well, I would argue that he needed a palliative approach to medical care, an approach which focused on symptom relief, not on life prolongation, which is the conventional approach certainly in the United States, in much of the developed world, and I think is likely to become the approach in many parts of the world. He also needed technological interventions to maintain his independence. I'm going to skip these in the interest of time and just remind you of some of the examples of technology that helped Sam remain independent. His wheelchair, in this case an electric wheelchair, a computer to connect to the world. This is a special form of a computer that's simplified to make it easier for older people to use, and then his hearing aid. Let's move on to the story of Alice Smith, a woman with dementia. She was 78 years old. She had moderate dementia at the beginning of my story. She lived in a nursing home. What I mean by moderate dementia was she could still carry on very brief conversations with her daughter. She drove her daughter crazy because she kept asking the same question over and over again, and within an hour after her daughter had left, she completely forgot that the visit had taken place. One day, Alice fell, trying to go to the bathroom. She broke her hip. She was hospitalized. She had hip surgery. And she had a complicated and very difficult hospital course where she became very confused, more confused than usual. She was physically restrained to prevent her from hurting herself. She lost interest in eating. She became dehydrated. She had one problem after another. She managed to survive that hospitalization and go back to the nursing home, at which point her daughter decided that she really wanted to focus primarily on comfort for her mother. So over the next 3 years, Alice stayed in the nursing home, where the aides who provided care for her became extremely fond of her. They combed her hair just the way she always liked it. They saw pictures of her from when she was younger. They dressed her in skirts because she'd never approved of pants for women. When musicians came to the facility to perform, she smiled and tapped her feet and clearly enjoyed their presence. In terms of her medical problems, she was treated multiple times for urinary tract infections with antibiotics and then ultimately developed pneumonia. She was treated again with antibiotics, but only as long as she was able to swallow pills by mouth. And then she was treated for comfort exclusively, treated with oxygen for her shortness of breath, with antipyretics for her fever, and she lapsed into coma and died. So what mattered to Alice? In the physical domain, comfort was the most important thing, and her daughter felt it was still reasonable to try to prolong her life, provided that those interventions to prolong her life did not impair her comfort. And in the psychosocial domain, what really mattered to her was human interaction. So how was dignity maintained despite Alice's dementia? Well, her medical care focused on her comfort. She had an appropriate living environment with well-trained caregivers who appreciated that she needed human interaction, that this was the source of so much of her joy. And this kind of well-trained caregiver, unfortunately, is going to be increasingly difficult to provide as older dependency ratios worsen. This shows that the number of people aged 65 and over per 100 people aged 20 to 64 who presumably can provide their care. And this number has been growing over time. This shows time and different regions of the world. It's really been growing quite dramatically in all regions except Sub-Saharan Africa. And the final example of someone who arguably is not aging successfully is a person who's dying. So this is the story of Jay Robinson. a 66-year-old retired engineer who was brought to the doctor by his family because this man who could always do very complex calculations in his head could no longer even figure out how much of a tip to leave in a restaurant. He had trouble finding words for the most basic things, this man who'd always been extremely articulate. He had a head CT scan performed after a neurologic exam was extremely abnormal, which showed that he had a large brain tumor. He was referred to a neurosurgeon who did a biopsy and found he had an extremely malignant form of brain cancer. His oncologist recommended surgery and chemotherapy, which would prolong life by at most a few months. He would have had to spend much of those few months in the hospital getting treatment or in the doctor's office getting the chemotherapy, and the time that he would have been at home would have spent to a large extent being sick with the consequences of the chemotherapy. And not only that, but there was no guarantee that any of this would lead to improvement in his mental status. What it was offering him was simply prolongation of his life. His family members were devastated. They felt he was suffering, and they wanted him to come home. What his physician arranged was for hospice care, and his daughter took leave of absence from work to move in. He had a nurse from hospice who was sophisticated in managing his symptoms, was able to prevent him from having seizures, was able to address his incontinence and other very debilitating and demoralizing symptoms. And Jay died surrounded by family 2 weeks after enrolling in hospice. So what mattered to this gentleman? Well, in the physical domain, what he wanted was control of his symptoms, of the seizures, of pain, of management of incontinence. And in the psychosocial and existential domain, what he wanted more than anything was to feel his family's love, to have his prior contributions to society acknowledged, to feel that he had a legacy that would live on. And what made dignified dying possible for Jay? Well, there was the hospice team, an interdisciplinary team with expertise in management of his symptoms and in providing psychosocial support to him and his family. And he also had something mainly administered by hospice that's actually been called dignity therapy that focuses on trying to cultivate, even in this person in a very debilitated state, a sense of the continuity with his prior self, appreciation for his autonomy, and a sense of his legacy. And then, of course, what gave meaning to him also was experiencing the love of his family. So I've argued in this very short half hour that the lifestyle approach of the active aging model is certainly tremendously important to further the development of people who are robust. But that model tends to treat vulnerable elders as failures. This separation of aging into a negative and positive pole is really very perilous. And I think what we need to do is to focus on dignity or quality of life for all elders, which is going to be achieved in somewhat different ways depending on their underlying health status, depending on their culture, depending on their personal preferences. But in broad terms, I think those who are frail and demented tend to find that the main goal is maintaining their functioning, whereas those who are dying, including those dying of advanced dementia, tend to want to focus on comfort. So yes, doing this is going to be a challenge. There is no magic bullet, unlike the people who purvey this youth juice, which I discovered was selling for $200 a case. I'm not quite sure what a case is, but I don't think it's very much. It's not as simple as that, but I would hope that with the will, we can help assure that everybody ages with dignity. Thank you.
Okay, well, thank you very much, Professor Gillick. It's, I think, quite a thought-provoking presentation. We'll keep the questions for the moment, and we'll go to our next speaker, who is Dr. John Beard. He's the director of the Department of Aging and Life course here at WHO. He's joined WHO fairly recently and before has worked in the United States and Australia. And I will pass now to Dr. Beard to give the second presentation.
Thank you, and thank you, Muriel, for some challenging thoughts. I'm going to give what I'm calling a global view on aging, which is really some perspective on how WHO views the transition to older populations around the world. I don't think it conflicts with what Muriel's saying. I think it complements it. But at the end, I'll present our vision for a way forward, and I'd really welcome discussion on whether we need to amend the emphasis or maybe include or delete things which are there or aren't there. So I'm an epidemiologist by background. I like to start with a few epidemiologic-like slides and stories. When I was born, there were just 14 million people on the whole planet who were aged 80 or above. To me, that's incredible, 14 million on the whole planet. Because by 2050, and I hope to still be around, so in the span of a single lifetime, there'll be 100 million people of the old that Muriel's talking about, 100 million in China alone. There'll be 400 million globally. And that's an incredible change for society, and I think it's one that we're only just starting to realize, and one that we've really tended to overlook. There are a few misperceptions about this transition to older populations. The first one is it's fairly common in developed countries, and it is that we've almost weathered the storm, that aging has occurred, we've coped with it pretty well, now let's get on with the next hot topic. Well, in fact, we're about to enter the period of most rapid aging. And the other misperception is that it's not just going to be experienced by the developed world, but it's also going to be experienced and, in fact, more dramatic in developing countries. So I think this slide is interesting. You see the upright line there shows you where we are at the moment in 2010. And you can see the general transition to a steeper slope over the next 20 or 30 years. But to me, the most interesting thing is how those countries at the bottom of this figure move up, so that by 2050, as a proportion of the total population, there'll be more people over 65 in China and Brazil than in the United States. China and Brazil will be older than the United States. Another thing that's particularly important for what are currently developing countries is that this transition is going to occur over a much shorter period of time. So that for Brazil, which will have more old people than the UK, France and Germany combined by 2050, if you look at the pace of that change, France had 115 years for the proportion of its population aged over 65 to double from 7 to 14%. Brazil will just have 21 years to make that same transition. That means they've got 21 years to put in place the infrastructure that's necessary to deal with it. Pensions, healthcare, long-term care, all of those things. They've got 21 years to do it, whereas France and most of the developed world had over 100 years. And just to give you a feel for what this means for the whole population, because somebody said to me, oh yes, but surely there's still all the kids that will be supporting those older people. This is a population pyramid for Thailand, which is not a country that most people think of as a rapidly aging community. But what you can see, as you go up the pyramid, you're looking at increasing age, and on the left you have male and female. What you'll see over the next 50 years is an incredibly different society. Now, I thought I'd try and give you an idea of what it might be to be an older person in these communities. So I've got a couple of case histories of my own. This is Barton Zazinga. Barton is 76, and he lives in Uganda. What you see on this slide is a photo of Barton, his wife, and his grandchild. And the reason it's his wife and his grandchild is his son and his wife both have AIDS, and in fact probably have died by now. So Barton, at the age of 76, has to support not just himself, not just his wife, but also his grandchild and also his children as they go through the dying process of AIDS. And to do that, he makes bricks. He finds it very hard. He has quite severe arthritis now. But he makes bricks to support all those generations, and he'll have to do that till the day he dies. And when he dies, one wonders what then happens to the other generations that are left behind. The issue about trying to create a society that supports older people isn't just about creating a society that helps that individual. It's actually about creating a society that supports the whole family that they link to. This is Gregoria Quispe in Peru. Gregoria is 85 years old. She was never married, but her father managed to leave her the flower farm, which you can see her collecting flowers on. Her day, every day of her life, consists of getting up before dawn, cutting flowers, walking 10 kilometres to the nearest village, selling them for maybe 1 to 2 euros, and then walking the 10 kilometres back to her farm, where she hopefully has grown some vegetables which she'll be able to eat, because the 1 to 2 euros that she's earned goes on electricity and water. Again, she will have to do this till the day she dies. What can we do to help these people in low and middle income countries? Well, the first thing is provide some form of financial security through a pension of some form, and not one that they contribute to, because neither of these people have ever contributed in any way to the formal taxation system. It needs to be a tax-funded universal pension at the most basic level, $1 or $2 a day, that will keep them out of abject poverty. And interestingly, when you talk to older people in low and middle income countries about what they would then do if they received a pension, it's not lie back and put their feet up under the coconut tree. It's actually think about how that can be leveraged from to create a better life for themselves and their families. So Gregoria in the last slide would employ her nephew to walk the 20 kilometres each day to the village to sell the flowers. Barton would change from making bricks to having a chicken farm, because it's a lot easier for him to do that, but he needs the upfront cash to be able to establish it. And what this slide shows is that to achieve this sort of system, which would keep most older people out of abject poverty, can be done for under 1% of the gross domestic product of most countries. And it's been already put in place by places like Botswana and South Africa. So it's utterly achievable, but countries and funding sources which may help them achieve these things choose not to follow that path. They're both healthy people, but as Muriel says, old age is often associated with functional loss as well. This is a man who has visual impairment. There are 300 million people around the planet at the moment who have severe incapacitating visual impairment that hasn't been managed. 120 million of them just need a pair of spectacles, and they don't have access to that, so they are essentially blind. There's 20 million people around the planet with cataracts that can be resolved for a procedure costing about $15. Other deteriorations that are common in old age is hearing loss. Again, there are millions of people around the planet who are basically alienated from their families and from their communities simply because they can't hear what's going on. This is, and many of these photos are from a group called Help Age International, which is a fantastic NGO which globally puts in place a lot of programs that try and address the needs of older people. And you can see here that their program is these very cheap, very basic hearing aids which basically give these people a life. What about, these are people who live in normal circumstances. What happens when disaster strikes? This is a photo of Janine Michel, who lives in Haiti, and you can see that's her home behind her, which was destroyed in the earthquake. And it's not just people in low and middle income countries who suffer in natural disasters. This is a photo of the Superdome after Hurricane Katrina in New Orleans. Older people were almost systematically marginalised, as is the usual case in this disaster, and, for example, were among the last to be evacuated from nursing homes, and in some instances not evacuated at all. So what can you do about that? Well, you can relatively easily change the humanitarian response system, so at least they consider older people a vulnerable population and put in place some strategies to deal with them. Or you can provide them, older people after a natural disaster in the reconstruction phase, with basic resources which allow them to develop some form of financial security. So this is Maria, who's in Banda Aceh, and after the tsunami, she was given a very modest amount of money which allowed her to make some ice-making equipment and some cake-making equipment, and now she has a stall and can support herself and her family. So that's a picture of what it's like in a lower middle income country. But I think in general with aging, there's two very important questions. When we talk about aging, why is that occurring? Is it because people are living longer, or is it just some statistical blip because people are living through childhood? And if they're living longer, are people living healthier? Or are we stretching life in the middle? Or are we just stretching at the end so people can live longer, but they live with more disability and more problems? Well, the evidence on the first question is actually very clear. This is a table that looks at the contribution of different ages to increasing life expectancy over the development cycle. And so what you see in the beginning as a country starts to develop, the vast contribution of increasing life expectancy comes in the first few years of life. People surviving childbirth and surviving childhood. But what you can see is that as development continues, it moves to the other end of the life course. So since the 1950s, it's the major contribution in the developed world has been for people over 65. And what I think is particularly important is since 1990, the major contribution has been increasing life in the over 80s. So the sort of people that Muriel's talking about are going to become much more prevalent, and we need to be coming up with strategies with how to deal with that and how to make their lives meaningful and to foster their contribution to society. The second question, if they're living longer, are they living healthier? We don't know the answer to. It's an absolutely basic question, but really we've got no idea. In the developed world, there's some evidence. Muriel presented one suggesting that disability rates in older age is less. There's some indication that even though chronic disease is more common, it's occurring later than it did maybe 100 years ago. But that's very mixed. There was a study looking at 12 countries around the world, and in some that wasn't apparent, and in some it was. In lower middle income countries, we really have no idea at all. And it's quite possible that older people in lower middle income countries have quite different morbidity prevalence in older age than is the case in the developed world. And there's two reasons for that. One is they may have less access to basic primary care, which means they can get early screening for chronic disease, they can get antihypertensives or have diabetes identified and managed. But there's also the suggestion that part of the reason people are living longer and living healthier in the developed world is that 50 or 60 years ago there started to be a lot of social changes where there was better nutrition for younger children, better nutrition during pregnancy. The type of work that people did over their life changed to become much less physically demanding, and so when they got to older age, they were in a much better position to actually to deal with the challenges that they face there. But I put this up because I think it's absolutely crucial that we answer this question so we can actually decide what are the implications of these changes in both developed and developing countries. Now, Muriel put a slide up there and talked about old age dependency, and this is a graph of the old age dependency ratio. I think this is only one way of looking at society, and one way of looking at this transition. Basically, it says that people over the age of 65 don't contribute and need to be supported by people of working age, and so it looks at the proportion of people over the age of 65 to that working age population. Now, this may be where I differ from Muriel a little bit, because I don't see this as valid, because 65 is just an arbitrary age limit. Why would you suddenly transition from being a contributor to a non-contributor just because you crossed a birthday? Many people, and one of the reasons we do try and promote health across the life course is to ensure that people can continue to to contribute even to quite old age. And the evidence from places like Japan is that even up to the age of 80, the majority of financial flows are from older generations to younger generations, not the other way around. So one of the reasons I think there has been this dualism and this perspective of emphasis on healthy aging has been to change the way that society view older people and to take away the stigma of being old and to take away the associated barriers that come with the ageism that follows that. So anyway, even if we think of dependency ratios as valid, what you can see here on the far right is that for Japan, at the moment, the dependency ratio is about 30. It has yet to double. Even the oldest country in the world still has a way to go in terms of the aging transition. But I think we should look at this idea of dependency in a different way and look at it in the whole cycle of economic development, because it's not just older people that traditionally place the burden on society, it's also younger people. And as a country enters a cycle of economic development, what happens is fertility falls and the number of children that need to be supported fall, and so you see childhood dependency falls. There's then this window of opportunity, which is historically an anomaly, which is where we are at the moment, where overall dependency is low. It's the opportunity for countries to build the capital and the infrastructure that they need to deal with the changes that are to come, which are going to take us back to a more normal, although different, pattern. And I think this is the challenge. How can we widen this window of opportunity? How can we maximize on it? How can we take the time now to set countries, position countries so that they can deal with the transition that's ahead? And so what we argue is that by taking a life course approach and by promoting health, preventing chronic disease across the life course, you can ultimately delay the dependency of older people, because, as I said before, just because you become 65 doesn't mean you become dependent. If you can remain healthy and you live in a society that allows you to remain engaged, you can still be productive. So we identified 3 key areas which need to be addressed to deal with the transition to older populations. And the first one is prevention of chronic disease and promoting health. It's the importance of health, and it's something that is totally neglected when we look at cycles of economic development. The development agencies look at the here and now, but what we should be doing is focusing much more on the prevention of chronic disease and putting in place the things which will allow people to remain healthy, because it's in the economic interest of the country that's involved. The second is, if you can keep somebody healthy, then if you can give them some financial security, and if they live in an environment that allows them to remain engaged and allows them to remain productive, then they can continue to contribute. We have a fantastic program here at WHO that's being launched on Monday, actually, in New York with Michael Bloomberg, called the WHO Global Network of Age-Friendly Cities. It's basically looking at how you create the social and the physical environment that allows older people to remain engaged. And we have over 100 cities from around the world, national programs in France, Slovenia, Ireland, and essentially a national program in Canada. And more recently, we've been talking with China about a national program of age-friendly cities in China that try to achieve just this. But then the final thing we mustn't forget, and this is where I very much agree with what Muriel was saying, and this is a slide that I used a couple of months ago at the Global Conference on Aging in Melbourne, and I haven't changed it, and you'll see that I have long-term care in capital letters. That was always there. But we need to have access to age-friendly primary health care. It needs to be integrated. We need to be able to screen and have early detection of chronic diseases and ameliorate the consequences of chronic disease. Older people need to have access to affordable medications, and we need to have a skilled and trained workforce. And we don't even have one at the moment. But as Muriel says, as the population increases in this area where there's going to be more need, the working age population will shrink. So how do we make sure that in those circumstances the workforce needs are met? Another challenge at the moment is they're being met in many developed countries by taking from less developed countries. by taking what is already a limited resource. That is not a sustainable solution, and in fact I don't even think it's a just short-term solution. And then, as far as long-term care goes, there was a study in Australia which looked at projecting forward epidemiologic trends and trying to look at what would be the financial consequences of ageing on the health system. And it showed that healthcare costs over the next 30 years will double. But at the same time, GDP will almost double. And so the impact on the total economy of the country is probably not as significant as we tend to worry about. But more importantly, for my point here, only a half of the doubling was due to ageing alone, and a half of that, so a half of all the contribution of ageing to the increase in healthcare costs was due to one condition: dementia. Think about that. And think about the figure that Muriel showed you earlier, which showed the increasing prevalence of dementia from 35 million now to 115 million in 2050. And think about that the prevalence, the absolute number of people with dementia in low and middle income countries is going to be multiplied by 10 on what it is today. If you think about the challenges that confront an older person with dementia in the developed world, what if you develop cognitive decline in a low or middle income country, what is your future? How are you managed? What happens to these people? Where do they go? So this is my final overhead, and this shows you gives you an idea of how we're planning to move forward as a department and as an organisation. One of the key things is to make sure that what we do is based on good evidence. And as I suggested before, when we were talking about morbidity, there's a shortage of good evidence on which to base our decision making. So we need to build that evidence base. One wonderful way that that's happening is through a study called SAGE, which is headed by Somnath Chatterjee, who's over here. SAGE is following older people in 6 low and middle income countries around the world. So there's China, India, South Africa, Ghana, Mexico, and the Russian Federation. A total of about 50,000 older people in a longitudinal study, which starts with a extensive face-to-face interview with some physical assessment and taking of a blood sample. And it is now being funded by the National Institutes of Health as a longitudinal study, and so those people will be followed over time. So for the first time, it will really give us an idea about what it means to be an older person in a low or middle income country. We're also looking to try and link the people who are involved in research like that and other aging research with policymakers around the world, so with themselves and with policymakers, so that we can get a much more coherent global approach to knowledge generation, and we can better link good research to good policy and practice. The next cross-cutting theme you'll see there is advocacy, and that's basically what I've been telling you today. There's two sides of this story. The one is that these aging populations present a very major challenge for society, but the other is that if we meet that challenge, if we address the needs of those populations, then they are a wonderful resource that's been overlooked and neglected. And it's an exciting challenge about making that happen. So that's advocacy. And then 2 streams of activity. The first one is what you would typically think that WHO would be involved in. And we identify, and again, these are from a previous slide, so I haven't included these here just to keep Muriel happy. Developing models of age-friendly primary health care in both developed and less developed countries. Looking at frailty, getting a much better idea about why people become frail. Can you identify frailty early? Can you even reverse it for a period? And if not, how do you manage it? Dementia, as we've talked about, and then coming up with models of long-term care, particularly in lower middle income countries where almost all long-term care is provided in the home by family. How do you support those people to do that in a way that's not going to be destructive for the family as a whole? Workforce development, and also dealing with the very significant issue of elder abuse, which can range from outright physical abuse to much more subtle means, for example, the control of older people's bank accounts and things like that as they become older. But then the other stream of activity which we've placed a big emphasis on, and this is probably where I do vary from what Muriel says, is looking at the environment, development and health promotion and how you can actually create a society that keeps older people healthy and allows them to remain engaged and productive. And to do that we have our Age-Friendly Cities program. We're also looking at coming up with guidelines for health promotion across the life course and for older people. We're looking to try and bring the humanitarian agencies much more in line in terms of their response to older people in emergency situations. And finally, trying to make help member states that currently are in the early phases of development to understand that ageing is a crucial issue that they need to deal with, and the earlier that it's dealt with, the more manageable it will be and the better it will be for their long-term economic growth. So thank you. As I said, I'm very open to suggestions about how we might amend this if we need to put more emphasis on different components, or if there's things which you feel we've left out altogether.
Well, thank you, John. I'll now pass it over to Dr. Sanjoy Bhattacharya, who is from the Wellcome Center for the History of Medicine, who will moderate the discussion.
Thank you, Hooman. Thank you to both the speakers for wonderfully thought-provoking presentations. I mean, could I start with a question for John? You make a link between increase in GDP and the possibility that perhaps funding levels might not suffer for the support of aging populations. Is that link guaranteed in your view, or does there have to be specific advocacy to ensure that a richer nation does not forget its aging populations?
I think there's two aspects to it. The first one is that if you look at increasing health costs, if you look historically, the vast majority of that increase has actually come from countries becoming wealthier. And as they become wealthier, people tend to spend more on healthcare. There's also a greater use of technologies. And then there's the contribution of aging. So I think in that sense, that will probably continue. But in the sense that we need to create a just society and one that maximizes on the benefits of population aging, it's not inevitable at all. And in fact, the argument which I'm trying to put is that it will give countries a competitive advantage economically if they start to deal with these things earlier in the cycle. And to that extent, some countries will do this, and I think Botswana is a terrific example, South Africa. And by putting these things in place early where it's affordable and then there's only incremental changes to a system that's actually effective, it's much more manageable. And whereas a country which waits till it's up at the end of that slope, it'll be a much harder transition for them.
Muriel, one of the things I didn't see in your talk was sort of the American government's attitude towards WHO initiatives, towards sort of a global, trying to create a global perspective on aging. I mean, in your own research, have you seen an engagement between American government, federal policies and WHO policy at all?
Well, I certainly don't want to speak on behalf of the American government. You know, my focus has not been so much on the international situation. I mean, I think there is growing interest in that. I presented a perspective that's more a clinical perspective, so I can't really say more than that.
Can I should open to the floor, sir? And could you please identify yourself?
Thank you very much for the wonderful presentations. It appears to me that being a novice in the field, what is striking is that there are two drivers. One is cultural and one is biological. Given the predispositions of biological aspects, aging and the disease trends, I'm not going to sit on that. But I think culturally, I don't see from the WHO side the advocacy being the blank slate in that space. An effort to be made of culturally sensitizing the young people and culturally sensitizing in such a way it's culturally appropriate, so that some of the attributes of what I would call as reducing the pressure on the people when they age, which largely comes from we ignoring them, the younger population ignoring them, and the younger population not attributing or understanding the problems they go through. I mean, I can self-reflect my own family, and I can see some of these the lines that can fit the curve there. So my question is, I think, considering this is WHO, what kind of advocacy elements that we need to embed that is neutral enough for the member countries, at the same time a message that is true so that countries can adapt a program, a campaign, not just giving space for the elders to sit in a bus. I mean, while that is very much on the line, but in the aging process, how can we embed this as a cultural change in the next century from the shift that we have seen in the past? So it's more for you.
Identify yourself for the record.
I'm sorry, Ramesh Krishnamurthy from Health Metrics Network.
I think that's a fascinating question, and we could spend a couple of hours delving into it. A few points. I think there's we tend to think of this transition occurring in a static social milieu, and in fact that's not the case, because society and culture is also changing at the same time, and that's not necessarily going to be a change that makes it any easier for older people. In many countries there's increasing disjunction between generations and marginalisation of older people, and in some senses the positive pictures that Muriel gave were always of older people in their families, but in many places younger generations have shifted to the city to find employment, to find economic prosperity, and there's also cultural perspectives. So for example, in Japan, it used to be that the vast majority of older people lived in an extended family, and now it's only the minority. And in Japan now, if an older person doesn't live in an extended family, their contact with the rest of their family is less than in the United States or in Europe. And that transition has occurred over just 20 years, and that's quite dramatic. And I think there's an expectation in some countries, particularly in Asia, that traditionally younger people have looked after older people. We've looked after it in the family. Well, first of all, that was when there were just a few old people and a lot of young people. So I'm not sure if that's actually even possible anymore. But it also risks that older people then are really seen as a burden, and the relationship is one about, I have to support these older generations. And so, I think looking at how we can change those perceptions is absolutely crucial. And in some respects, WHO makes it worse. I mean, we identify a Department of Old People. It's the Department of Aging, really. And then we have the Department of Child and Adolescent Health. We have a Department of maternal. We have maternal and child health, and we tend to look at programs in those areas and deal with those populations, and not actually look at them in the whole context of the broader family and society. So in many of those projects, it may actually be better if older people were involved, because it's the grandmothers who are going to often be advising a woman how to give birth, and they may listen to them. So I think it's multi-layered, and I think there's many steps in that. I think programs which foster intergenerational links are important. I think we also need ourselves to be thinking about how we artificially categorise people into different age groups, and there's many things which I agree may be a solution to what is a crucial question.
Questions, please?
Yes, thank you, Dr. Beard, for the interesting introduction. Sorry? Oh, Deidre Roberts, World Health Press. And I have spoken to Dr. Beard before. And I just wondered, I just was looking at recently, last week, 108 countries signed on to a declaration for the report on from the independent expert on the question of human rights in extreme poverty, Magdalena Carmona. And she was fortunate they had a gala. There were 108 countries that signed on. But her whole report is all about the elderly and pensions for the elderly. So when we look at poverty, are we really saying that mostly the poor people are the elderly? And once, if they do have these pensions, which she goes on to say is their social right and their human right, and it's, she quotes the Universal Declaration of Human Rights, etc. Are we going to see the reduction in poverty? Is this a way to treat poverty at the same time? I'm just opening that up for kind of a thought-provoking question.
Yeah, well, certainly it's the case that there is a link between poverty and aging, and that I don't know that it would decrease, how much it would decrease poverty to solve the problems of poor old people, but it would be a good start. I think certainly economic factors influence the way aging is experienced throughout the world. Some of what I was presenting indicated that even when you have no problems of poverty, that you still have very unfortunate experiences of aging, and that even in this situation where there are adequate resources, we still have a lot of work to do.
So that's the shifting of the resources in the wealthy countries, but the poorer countries are the ones that really need the heavy hand of looking after the elderly. And do you think this, the fact that 108 countries signed on to a human rights declaration for the elderly to receive pensions actually, do you think, what kind of an impact do you think that'll have? Perhaps Dr. Beard in the developing countries.
I think it's an important step, but I think that we think it's a magic bullet. And in fact, it doesn't factor health into the equation. And it's a crucial missing piece of the equation, because if you're an older person, yes, it would be great to have some sort of financial help in terms of a pension. But if you're an older person who's sick and needs health care, and you live in a country where most of the health care is delivered out of pocket by unregulated and uncoordinated health systems, almost all of that pension can automatically just be going on health costs, and often to something which was eminently preventable if detected earlier, and to one that could be treated much more effectively if you actually had an efficient healthcare system. So I think that, and I was actually involved a little bit with the development of this. I tried to argue very strongly, and I think it's been worded a little bit differently to take some of this into account. I think that we need to be thinking much more in terms of what's called a social protection floor, which includes pensions, but it also includes the delivery of some form of health care. And we also need to be factoring into that, how do we look after people who reach frailty or other states where they really do need long-term care. And in most developed countries, it's not going to be resolved by either of those things. If that person, though, at least gets a pension, it gives them some dignity and some respect in the family, and they're viewed as a positive rather than just a drain on resources. And I think that moves a little bit towards overcoming some of the intergenerational problems I was speaking about before.
Sir, and can you identify yourself?
My name is Frank George, and I work here in the partnership with the United Nations Reform Department. My question goes more economically or as politician. One of the first solutions which is offered is to get the retirement age, to prolong the retirement age. And some liberals and other parties would even argue that then as well the health status of people who work longer is even better. And it gives them the monetary terms to finance. Does WHO have an opinion on that, or is it politically kind of too sensitive to tackle it?
Well, I have an opinion, and it is that I think that's a good idea. There is a real issue in terms of increasing costs for society, and we have in many countries ridiculously low mandatory retirement or systems which push people to early retirement. I mean, the mandatory retirement age for WHO is 62. My predecessor, who was the director of aging, was forced to retire at 62 because that's the rule, and it wasn't because he couldn't continue to contribute. Here's a really classic example of how society is structured to marginalise and prevent older people contributing, and then we blame them that they're a burden. There are many ways that you can address the cost issues which come from increasing populations, and there's things like migration, there's reducing the level of pensions. But I think if you increase the retirement age by 1.5 years, it's something like 20% of the cost of pensions is reduced, because it's a pyramid, and it's the young people who are the most costly part of that pyramid. So if you shift it up a little bit, you know, then it really is a very cost-effective way of dealing with the change. But on the other hand, you need to make sure that the people who, even at 65, between 65 and 67, who would then be missing out, actually are in a society and in a health state that allows them to continue to contribute. If they're not, then, and you believe in a social approach to welfare, then they need some form of support to help them through.
And is there any evidence that there's a relation between being healthy and being still working? If you stay longer healthy, is there any kind of evidence?
Oh, Somnath is nodding his head. I don't think there's evidence that working does that, but there's certainly evidence that social engagement does. And there's also evidence that when people stop working, they also stop what are quite a range of healthy behaviours. So they do less physical activity when they stop working. They have less social engagement. All of these things we know are good for health. So it makes sense, but I'm not sure if there's hard evidence out there. Somnath, you can disagree, but I don't know.
I think Thompson has a question.
Yeah, thanks, and thanks to both of you, Muriel and John. Really enjoyed both of those presentations. Can I be heard all right? I'm a little bit husky. I'm one of those people, John, that you're talking about. I was kicked out of here last year against my will, and as you can see, I'm not before time, perhaps. And it's actually not so long ago, in recent years, that one of our former DGs, I think, was wanting to bring the retirement age down. Anyway. It occurs to me in listening to you both, and one of your slides provoked the idea that I wonder whether you've taken it into account and where the potential benefits are of what I would call the internet elderly. There's a first generation of elderly people now in existence who have grown into the internet as they've grown older. And the possibilities of that being of some benefit to, I don't just mean using websites, but also emailing and mobile telephones and all the other communications that go with that. I just wonder whether you see any potential benefits there in terms of people who otherwise might be marginalized or isolated or who lack social contact, but who can get access to information very readily and can communicate to other people very readily and can find, whether it's good, bad, or indifferent material by searching on the web for advice about how to either be cared for or how to care for someone who is elderly. It seems to me that there could be hazards as well, but I wonder whether you see, first of all, any positive elements in there.
Yes, I think that technology of all kinds, and the internet in particular, have a offer tremendous possibility for helping people with particularly people who are frail and people even who have mild cognitive impairment. So I think that there is enormous potential, and I think we've seen a number of innovative applications of technology that do help people. I would certainly share, I don't disagree with you on that slide there, that the critical importance of environment, and I would include internet access as a part of the environment and a way to be in touch with the environment. That's why in my story of the frail individual, he was using a computer to develop an interactive website. So someone who's got hearing impairment or who may have limited attention span, who may get fatigued easily, may have physical pain, may have difficulty with transportation, depending on what sort of environment you live in, can overcome all those barriers through the internet. So hopefully, as more people have go into aging with that degree of sophistication, it will become possible to develop even more sorts of applications.
Yeah, I think this is actually a really exciting area. I was recently at the conference on gerontechnology in Vancouver. And gerontechnology, I mean, aging used to be viewed as a fairly dowdy, dead-end, low-profile specialty to get into or interest to get into. I actually think it's the cutting edge, and this is one of the areas where it really is stretching the envelope. I'll give you an example, and I think you Muriel, one of yours, the person who even in his dying days was able to continue to go home and work from home because of the access to the internet is a good example. My mother is 78. You shouldn't say that, I guess, but she's nearing the old age. She lives in Australia. I keep in touch with her using Skype. We video conference. And she just completed a unit in fine arts at Oxford University by distance. These things are inconceivable 10 years ago. If you look at trends in internet use, the peak, in terms of, if you look at across the ages, the biggest proportion of any age that uses the internet is 20-year-olds. That's what you'd expect. But if you use the internet, the heaviest users are over 60s. That's already the situation in the UK. And there's a lot of IT companies which are really starting to understand this. And so, for example, Cisco Systems have a fantastic project which we're working with them a little bit on called Aging Well in a Connected World. And it's really looking at how you can maximize some of the advantages of the already widely used and commonplace technologies, not even looking at new technologies. And there, I mean, some basic things which are useful for an older person is a GIS, which they press where they are, it'll show them the nearest toilet. You know, I mean, very, very simple things like that. There's also ways of using technology to monitor the behavior and health of an older person in the home, so that if that changes, there's some early detection. So even the use of a kettle and how frequently it's used and the patterns, if they change, there can be warning signs sent to a clinician or home care that that person may need visiting. I mean, there's all sorts of exciting things happening in this field, and you know, I think that it's going to be disabled people and older people who have physical limitations who really realize that this completely transforms their access to the world. And it's not just about their access to knowledge. It's not just about them hearing what is available or what's happening out there. It's also about that it gives them a potential to connect and influence what's happening to them. So I think it's incredibly exciting.
Just to add one thing on that, I think technology, now moving beyond the internet but to other manifestations of technology, actually may be able to help people with cognitive impairment as well. You could have someone able to stay longer in his own home if he got very frequent reminders of things that he needed to do, things that human beings get impatient providing. Reminding at 20 to 12 that it's time to get ready for lunch, and at quarter to 12 to wash your hands, and at 10 to 12 to leave the apartment. So that you can have computers with infinite patience to provide as many reminders as might be necessary to help support individuals with cognitive impairment. You're still going to need human beings. So the dependency issues are going to persist. It's tough to have a robot give someone a bath or a computer give directions for taking a shower and not burning yourself. But I think there's a great deal of potential there. I just wanted to add one thing on the dependency ratios. I agree that the number, looking at the fraction of people over 65 divided by the number of people between 20 and 64 is not perhaps the right number. I would love to see, again, not assuming that everybody over 80 is dependent, but the better number would be people over 80 or 85 per 100 individuals who are probably 20 to 64, because it's going to be tough for the 75-year-old to provide help for his 100-year-old mother. But I couldn't find any such numbers. So I think that I share your view that the dependency ratios that we have are inadequate, but I do think that it's getting at something important, and we just need to have the right statistics to capture it.
It is a two-edged sword, and I actually, in some respects, the existing dependency ratio is a good way of raising the profile of ageing and getting countries to realize that if they don't do something, that's what they're facing. Can I give you another neat example of the use of existing technologies? And this is a research use. One of the challenges for older people is falls, and particularly for older women, falls are a major risk factor for later institutionalization. And but we really don't know what are the factors? Well, we have some idea, but we don't really know why people fall, or what are the circumstances, and what are some of the factors that influence it. And there's one really neat study in Canada that is making access of all the remote surveillance cameras that are available, and they have millions and millions of hours of footage of this just randomly collected data, and they've entered a computer program in there which detects when somebody falls. And so they have real life footage of what happened when that occurred. What were the things? Was there anything on the footpath, or did it just happen? And so, you know, just using that existing information, but in a more efficient way, creates a whole wealth of knowledge which can influence a whole lot of potential interventions.
Just to say, you need GIS for banana skins, perhaps.
Laura?
Thanks very much, Laura Gallery, Who Press. It's really nice of you to put up your whole department's plan here so that we can take pot shots at it, so I will. It really worries me when WHO programs say that they're going to do advocacy for something, because the aggregate effect of that advocacy is everything is an unmanageable, huge problem. And particularly when you have gone through a presentation where every single estimate, projection, ratio, etc. has it's not one single confidence interval. There's never a discussion of the counterfactual. There's never a discussion of possible a healthy cohort effect that's affecting people being able to reach an elderly age now because of what they lived through as children or in their early adolescence. That's not the case for the current generation. And the sort of the global picture is WHO exaggerates everything. So I just wondered, how do you cope with uncertainty in these projections, and how do you communicate that? Thanks.
Well, the population projections are from the UN, and they're actually they do a range of estimates, and these are the low to the middle estimates. So in terms of the population changes, I think they're actually conservative, and they don't take any account of the impact of improving healthcare and other things that do appear to be occurring anecdotally. So I think the estimates are conservative. We could put confidence intervals around them, but these were slides which I used for a talk to the general public, and so I think they probably confuse rather than actually add light to anything. And as I was saying before with the advocacy, in fact, we're not emphasising the changes and the risks. We're emphasising the opportunities and the way that people can actually address the potential risk, which we again don't think which is understated, if anything. So now the problem then is that we're operating in a field of ignorance. But I mean, in terms of projecting the future, I think I have a lot more confidence in projecting the future of world population and aging patterns than most things we can talk about in 2050. Because barring a war or pestilence, it's unlikely that they're going to be less than what I'm saying. And I'd like to see projections of diseases or anything else which are anywhere near as accurate as that. The problem is this ignorance which we have about is that life being stretched at the end or in the middle? And in the absence of that, it's pretty hard to put any justification to sort of the interventions we're talking about. But for example, with age-friendly cities, one of the things which we're emphasising is the need to constantly evaluate and explore whether the program is making a difference. Because if it's not, it's a very expensive intervention. And this is why the key thing for the department is to build everything and to build the evidence base and knowledge generation to enable us to do the sorts of things you're talking about. Maybe we need to change the word advocacy to another word. Awareness raising or something else, but I don't think that what we are doing is probably different than what most departments are doing, and in fact I think we've got more evidence to support what we're saying, than certainly in terms of the changing need than most other areas. But it's an interesting point.
Just add to that, though I'm not in the business of having to defend the World Health Organization.
Feel free, though. Feel free.
Just the only thing I would add to this slide under your primary health care, you leave dying out, and that is one area where the probability of its occurrence is 100%. So I would include something specific about the dying elderly under primary health care.
Woman, you have a question.
Well, it was just, I mean, Lara covered it, but but it's just one bit of that, you know, you're saying you have great confidence in the projections for 2050, but I mean, we have all this talk that a younger generation is coming up, which isn't as healthy as the generation that's now living to a long life, and, you know, with obesity and binge drinking and drug addicts and all these epidemics that you see, you know, diabetes and all these other things that are feared. I mean, what is the probability, in fact, that that a coming generation will actually live as long as current generations are living?
Well, that is certainly a risk. Well, it's not a risk, but it's a possibility that the trend may go the other way. But those changes are generally only occurring, or mainly occurring, in developed countries. The developing world, which is where most aging is occurring, is based, and the projections are actually based on current patterns of mortality, and if anything, they're probably going to improve. I think there'll be movement either way, and you do need confidence intervals around these things. But this is a low, medium estimate of what will occur in the future. I mean, it's a good point. It's not cast in stone.
I mean, obesity and things are rapidly increasing in developing countries as well. I mean, you know, if you look around.
Well,
Young people, even in developing countries, you'll be surprised how the physiognomy of young people are getting bigger and bigger.
Well, there is a traditional shift, the epidemiologic transition, which sort of parallels all this. But really, I think we're arguing around the edges. You know, the transition to older populations is inevitable. I mean, you only have to look at Japan, China. It's occurring. In fact, if you look at the projections and how they've been estimated over the past 20 years by the UN, the projection that there have been several ceilings which the UN put on their projections, expecting that was a maximum life expectancy which countries could move to, and it just seems to every 10 years they seem to have to get rid of that and extend it further. So there's pressures, as you say, in terms of increases in chronic disease from changed behaviour, but I think that there's also pressures the other way from changes in health systems and access to care. So I think in the wash it will probably all come out, and if the projections are inaccurate, it's only going to be to a small degree.
Okay. Sir.
Les Olson, WHO Bulletin. Whatever happens, there's going to be a fairly substantial need for medical care for chronic medical conditions and also for conditions specifically related to ageing, like fall prevention. And yet, one of the striking things about providing that care is that the evidence base for choosing treatment has systematically excluded elderly people, both in terms of the conditions in which younger people also suffer. The trials generally don't include anyone much over 65. And the evidence base for things like health promotion in the elderly, age-friendly cities is extremely scanty. Is fixing that issue part of the agenda?
Well, certainly it's something we advocate, that for clinical trials we should be looking at the response of older people and not excluding them, because I mean there are a range of physiologic reasons why older people their response may be different. I mean, there's also issues around the interaction of drugs and all sorts of things which we really have an inadequate understanding of. It's part of what I see as the workforce development. I guess it's not workforce; it's probably more capacity building. We need to have a much better understanding on what is effective in older ages, and to train people to be able to apply it.
But one of the obstacles is the ethical regimen and the precautionary principle under which ethical approval operates. That because in order to safeguard trial participants, it's customary to exclude participants at high risk of adverse events.
You mean the ones who are most likely to use the drugs?
Yeah, that's right. But also, if you you exclude people who take multiple other medications because you don't want interactions. You exclude people with renal impairment. And that means that even if you nominally include older people, they're excluded because of their risk of adverse events. So there has to be a shift in the ethical regimen as well.
I agree entirely. I mean, let's put this in perspective. The department, I think, is one of the newest, if not the newest in WHO, and probably the smallest. And I have to say that what's up there on that chart is aspiration as much as existing practice. And I think the things you're talking about are really important, and they're not even, you know, we're not even able to aspire to them.
I would add that one way we can get data that is relevant to making choices about medical care for older people is with careful collection of data, large amounts of data, epidemiologic data, so that you don't necessarily have to have a randomized double-blind trial looking at every particular intervention, that you might learn something about the efficacy of a particular intervention in a group of people who have multiple comorbidities. And we need to develop more sophisticated and complex ways of gathering huge amounts of data and analyzing that.
More questions, comments? I mean, if I could just perhaps quickly, is there, no? I mean, John, one of the things I notice about this slide we have up is it doesn't seem to be making distinctions between urban context and rural context. I mean, just the fact that you're talking about age-friendly cities seems to me to suggest that you assume a certain transferability of models to increasingly urbanized rural areas, or how does that work? Because yes, in countries like India and Brazil, you have rapid urbanization, population moving from rural areas to urban areas. But there are also significant sections of the population remaining in rural areas. So since you highlight developing countries or less developed countries, how do we then create a model for rural areas?
Yeah, in fact, this is an old slide, and we now call it the Age-Friendly Environments Program, and within which is the Age-Friendly Cities Network. But we also have, particularly in Canada, there's a lot of work being done in rural areas, and it's something we're looking to expand to. It's also, I mean, if you can imagine trying to set a program that applies to New York City but also Nairobi is quite a challenge. You know, even within cities there's a lot of heterogeneity. So, but I mean, in our work with China, they are very, very aware of the difference between living in Shanghai and living in a rural area, and are trying to address that. I mean, it's an enormous challenge for them, as it is for many low-middle-income countries.
Well, thank you, and I'd like to thank everybody, including all our WHO colleagues from different departments, Owen, Gail, Tony, for supporting us, and thank you to the speakers for joining us. And perhaps we can continue the discussions over a cup of coffee downstairs. And thank you all for coming. Thank you very much.